So in general, we see two categories of patients. Patients that just have some sort of an injury and have a specific history or identifiable event in their life that they think started this. And the second group of patients have no idea what happened. They just started developing pain, weakness, and at some point it becomes an impairment to them. And so they tend to present to a specialist in cervical spine problems.
Patients who have the arm pain, nerve pain, describe it as a toothache. Toothache that goes down their arm, runs from the shoulder down to the fingers, and they just can't escape it. It is that toothache that no matter what position you are in, it remains.
So when someone presents with a degenerative disc disease and someone who's failed conservative treatment of physical therapy and injections and time, the treatment is to remove the compression of the nerve. So that's typically done from the front of the neck, where we remove the disc to completely decompress the nerve, and then we need to replace that disc, typically with a fusion.
Number one is the structural aspect of the bone. Number two is to have something that mimics bone in its pore size and its ability to remodel. And number three is to have some either cellular idea to induce or cellular activity to help bones heal.
As a surgeon, you're looking for something that is safe. You are looking for something that produces or that forms bone solidly where you want it, when you want it, in the way in which it was intended.
But historically, the treatment was to go to their pelvis and to take a saw and take a wedge of bone out of their iliac crest and then transplant that into the neck to give the right biological environment for them to heal.
So we've used autograft since the 1950s when we started doing this surgery. In the 1990s, we started using allograft, or bone from a dead person or a bone bank. And then since then, we've started using more synthetic materials packed with either a synthetic bone, a demineralized bone matrix, a bone protein, a synthetic bone, or now we'll use implants with I-factor.
Unfortunately, there is not a lot of evidence in the cervical spine for the non-autograft, non-allograft materials.
So I-factor is a different product than the other technologies out there. It fits in its own category. It's a combination of a scaffold as well as a peptide that attaches and activates the mesenchymal cells, the bone cells, to start forming bone in that location.
I-factor is an incredible technology that I think is completely different than the demineralized bone matrices, completely different than the BMPs, but yet it has similarities to BMPs because it's the only other technology that the company and the leaders have invested huge amounts of resources to get real data.
Therapeutics as a company has done a wonderful job about pushing those studies and trying to find out what do we as surgeons want to know, what do we want to see.
The efficacy data behind the IDE study is impressive.
I think one of the biggest advantages of I-factor is we have to look at its safety and its efficacy, the clinical data, its handling characteristics, and what we can do with it.
Economic aspect of it being significantly cheaper than a BMP, again with a reduced risk profile, also makes it very compelling.
I think in my entire career, it'll be one of the most revolutionary things we've contributed to the literature on, and to make a big difference in patients.
The surgeon has lots of choices to what to use in the cervical spine. And any surgeon wants to use a product that works, a product that's safe, and a product that has a good track record of human data behind it. And if you want to use all three of those criteria in the cervical spine, the only choice is I-factor.